is a brief overview of what we're going to cover, including epidemiology, some definitions, a little bit of the pathophysiology behind hypertension in children, the evaluation, and therapy. This is an interesting table that came out a few years ago comparing some myths and facts about why pediatric hypertension is in fact a problem. And it goes through some basic tenets which most pediatricians may recognize clearly as myths, but it's worth going through a few of them. The first is that hypertension is an adult disease, and obviously that's not true. The earlier data suggests that 3 to 5% of children have hypertension, and some data that I'm going to present to you suggests that this is even more so in children who are obese and have other conditions. Second is that pediatric hypertension is mostly due to secondary causes, and in earlier years that was the case, but now with increasing rates of obesity, we know that that's not necessarily true anymore, and that it's more so related to essential hypertension. The third myth is that childhood blood pressure is unrelated to adult hypertension, and we've clearly been able to demonstrate that there are studies that show that pediatric blood pressures track into adulthood, and that includes hypertension as well, and we'll discuss some data on that. The fourth is that true hypertensive target organ damage does not occur until adulthood, and we know that upwards of a third of children diagnosed with hypertension may already have evidence of vascular injury, especially left ventricular hypertrophy. The fifth and final myth in this paper was that the overall impact of hypertension on children is small, and that paper was an editorial that came along with a study that showed that in the years from 1997 to 2006, hypertension was the cause of $3.1 billion in hospitalizations for children, and that the rates of those hospitalizations are increasing. So with that background, let's launch into hypertension and start with some epidemiology. This is a paper that's now 10 years old, from 2004, that looked at a large school-based blood pressure screening program in Houston, where they described their experience with over 5,000 adolescents, of whom 20% were described as overweight, what we now call as obese. The prevalence of hypertension after 3 blood pressure readings was 4.5%, and the ethnic variability was all accounted for by body mass index, or degree of obesity. And this is a paper showing the rates of elevated blood pressures or hypertension after the first, second, and third readings. Focus your attention on the white bars, and with the x-axis being BMI percentile. And you can see that the rates of hypertension after the third reading, or the white bars, was about 2 to 4% for the majority of children. But when you get to the obese children, that jumped up to 11%. Similarly, a study looking at 8th graders from 3 inner city areas in Texas, California, and North Carolina, again looking at hypertension in an inner city population with a larger minority group, all of whom were non-diabetic. This paper was looking at hypertension among some other cardiovascular risk factors. But they demonstrated varied rates of high blood pressure, which in this study included both pre-hypertension and hypertension. And they were able to demonstrate a prevalence of 23.9%. As you can see from the graph, that breaks down by gender and ethnicity with a wide degree of variability, whether you're looking at whites or blacks or Hispanic or Latinos or Native Americans. And again, there's variability by boys versus girls. Interestingly, they also compared their data to that from the National Health and Nutrition Evaluation Survey from 1999 to 2000, which was some years earlier, and found that the rates of any high blood pressure, again, pre-hypertension or hypertension, in this study, compared to the NHANES data, was elevated regardless of subset of how that was evaluated, including race or ethnicity or BMI percentiles. Perhaps most concerning was the rates of obesity themselves, that in that study were 29%, while in the earlier NHANES surveys were in the rates of 15 to 16%. This is a paper looking at a large Philadelphia area electronic database of children who are presenting for well-child visits. And as you can see, what they're looking at here is males in the top, females in the bottom, stratified with prevalence of hypertension by BMI percentile going across the top. And not surprisingly, as you moved from the normal weight up to the obese categories, you can see that the rates of hypertension increased dramatically. Moreover, the prevalence of hypertension, the prevalence of those BMI categories, the overweight being the 85th to 95th percentile was 17%, about 1/6 of the cohort, and the obese made up 1/5 or 20% of the cohort. So again, reflecting the increasing prevalence of obesity as a contributor to hypertension in children. Unless you think this is a uniquely United States cohort or problem, this is a study from Switzerland from 2007, and the graph looks very similar to the original one from Houston, with rates of 1 to 4% of hypertension in children in normal weight or below 95th percentile, while when you jump up to the obese category, you get to rates of 15% for hypertension. And a more recent study from a very large cohort, almost 41,000 children from all over Europe, with a spectrum of ethnic groups and weight groups, the prevalence of hypertension was 6% in the normal weight cohort versus 40% when they jumped up to the obese or overweight cohort. There was no relationship between ethnicity and hypertension in the normal weight subject. However, in the obese children, the Turkish children had a higher rate of odds ratio of hypertension compared to the German or Austrian or Swiss cohort. So even in a European population, there's a variability in terms of ethnicity. With regards to tracking of blood pressure, the Bogalusa heart study was a large study that took place in the South some decades ago, and this is one paper from that very large study published in 1995 that compared a cohort of 1,500 children initially taken age 5 to 14 years and then repeated 15 years later. And the point here is to look at the rates of hypertension not only in the children who were in the normal range of blood pressure, but in the high normal range, and that over time they were at a much higher rate of developing true hypertension over time. This concept of tracking, namely that children with high blood pressure become adults with high blood pressure, and that even children with blood pressure that's in the normal range, but at the high end of the normal range, become adults with true hypertension. Looking at in reverse, of 116 hypertensive adults, 48% had childhood systolic hypertension and 41% had diastolic hypertension, again, reinforcing that concept that blood pressure in children does have a role in blood pressure in adulthood. The definitions of high blood pressure and hypertension, as the term we'll use from now on, was reestablished in what's known as the fourth report. This was published in the August 2004 issue of Pediatrics and updated norms from the first 3 reports that were previously published. There were a number of important changes in this report. It's also titled The Guidelines on the Diagnosis, Evaluation, and Treatment of High Blood Pressure in Children and Adolescents. The blood pressure norms were updated from more recent NHANES data, and some of the terminology was redefined to keep in line with the adult guidelines that had just come out prior to that, the JNC7. In the prior guidelines, we had 90th and 95th blood pressure percentiles, and in the fourth report, that was updated with 50th percentile to give a sense of what the average is in those children, as well as the 99th percentile, which became necessary in order to define the different stages of hypertension that we'll look at in just a minute. And the link for those guidelines is listed below, and that can be easily Googled as well. The definitions in this guidelines changed slightly. Previously, what was known as high normal blood pressure became pre-hypertension. This change was made for 2 reasons. The first is that the JNC7 guidelines changed their terminology as well. And the second being that the feeling that this was called some version of normal was somehow misleading, and that it should be rather viewed as a version of hypertension. And thus, pre-hypertension was defined as 90th percentile up to 95th percentile, or anyone with a blood pressure greater than 120/80. This second line was done, again, to be aligned with the JNC7 adult guidelines. Also, one can imagine adults, or adolescents rather, who were tall and had blood pressures that were at the 90th percentile in this pre-hypertension range. That would put them somewhere in the 120s/80s, and then they turned 18, and using the JNC7 guidelines, they would be pre-hypertensive at 120/80. So this was to help align those two. Definitions of hypertension were broken out into stage 1 and stage 2 hypertension. Stage 1 became the 95th percentile up to the 99th plus 5 millimeters of mercury, and stage 2 hypertension was essentially above stage 1. Who should have their blood pressure measured? Well, the guidelines reinforce that children 3 and over should have their blood pressure measured during every healthcare episode, while children under 3 should have their blood pressure measured in special circumstances. And looking at this table, which is excerpted from the 4th report, one can see a variety of conditions that could potentially lead to kidney disease of some sort or another, such as known renal disease or urologic malformations, a family history of congenital renal disease, treatment with drugs known to raise blood pressure, recurrent UTIs, and so forth. How does one measure blood pressure? Well, there's a picture in the guidelines that describes how that should look, but essentially the width of the cuff bladder should be 40% of the arm circumference, midway between the olecranon and the acromion, so midway across the upper arm. And that usually ends up with the bladder of the blood pressure, not the whole cuff itself, but just the bladder of the cuff, covering about 80 to 100% of the circumference of the arm. Patients should be sitting at rest for 3 to 5 minutes, and the cuff should be at about the level of the heart. The systolic blood pressure is defined as the onset of the tapping or Korotkov sound. The diastolic blood pressure was redefined as the disappearance of the Korotkov sound, where it had previously been defined as the muffling. There are some children who have the Korotkov sounds going down to very low readings, almost to 0 millimeters of mercury, and in those children, the muffling or the 4th sound should be used as the diastolic blood pressure. Now, in contrast to adult norms where blood pressure guidelines are based on target organ damage such as cardiovascular disease, heart attacks, and strokes, blood pressure norms in children are based on statistical population norms based on height percentile for age and gender. And it's also based on a manual blood pressure cuff of appropriate size on the right arm. That's important because there's a number of studies that have shown that manual readings and automated blood pressure readings are not interchangeable. And in fact, automated machines themselves are not interchangeable due to the proprietary algorithms that they use to define blood pressure readings in those systems. The earlier studies suggest that the machines tend to raise blood pressure about 5 to 10 millimeters of mercury over manual readings. So any reading taken with a machine that is questionable should be repeated with a manual cuff. Also important is that a small cuff raises blood pressure, and so that can give you a falsely elevated reading. In contrast, a large cuff can give you a falsely lower reading, but that effect tends to be less dramatic. We also know that leg blood pressures tend to be higher than arm readings, and this is not an effect of gravity, but rather transmission of the pressure wave down the vascular tree, and we use this fact to diagnose coarctation of the aorta, as we'll come to in a bit. Oscillometric measurements tend to be highly sensitive to movement, and anyone who's taken a blood pressure in a small child knows that when they start moving their arm around while the machine is inflating the cuff, those children tend to get quite upset, and the machine really doesn't know what to do with that information. What do you do with the reading that you obtain? Well, if the reading is normal, then it should be rechecked at the next scheduled physical exam. If the blood pressure is in the pre-hypertension range, it should be rechecked in about 6 months. If you get a reading in the range of stage 1 hypertension, it should be rechecked within 1 to 2 weeks or sooner if they're symptomatic. And if the blood pressure is persistently elevated on 2 additional occasions, giving you a total of 3 abnormal readings, patients should be evaluated or referred for evaluation within the next month. In contrast, if someone has stage 2 hypertension, they should be evaluated or referred sooner or immediately if the patient is symptomatic. One important aspect of this is the underdiagnosis of hypertension, and there are a number of papers that have demonstrated this. We're going to discuss 2 in the next few slides. This is a paper from 2007 that looked at electronic medical records from a large cohort in Ohio of over 14,000 children. They identified 507, or 3.5%, with hypertension based on readings in the system, while only about a quarter of those were identified as having hypertension by the physicians and the providers themselves. With prehypertension, again, 3.4% of those children were identified as having that. However, only 11% were actually identified by the providers as such. More recently, this paper is from 2 cohorts that were looked at in the middle of the last decade of over 27,000 children. In the first cohort, they had blood pressures measured at their well child checks, and that data was accessed where only 75% of those children had blood pressures measured. In the second cohort, families and children and adolescents were asked to recount whether they had blood pressures measured, and only 68% of them could recall having those readings. Adolescents tended to have more blood pressures measured, or blood pressures measured more often than younger children as well. Ambulatory blood pressure monitoring has come of age in pediatrics. This used to be something that was done primarily in adults, but there are ample data now in children that have shown its efficacy and its value in assessing hypertension. This primarily came about to look for white coat hypertension, and what this device does is at the port right over here, this is connected to tubing, which the patient then wears at the end of the blood pressure cuff. And this takes blood pressures every 20 to 30 minutes over the course of a 24-hour period, and that data is then downloaded and then can be looked at in terms of blood pressures trends over that time period, whether there's dipping of blood pressure as patients sleep. It can be used, again, primarily for white coat hypertension to assess readings that might show some lability in the office setting or might be abnormal, whereas in other settings they may be normal. They can also be used to document the efficacy of therapy when there's some question as to whether you've started a patient on medication and yet their blood pressure seems to be high and it doesn't seem to make sense. There's also a variety of data that demonstrate that that ABPM data, as it's referred to, has better relationship with markers of end-organ damage in children than office readings. And these are widely used in pediatric hypertension centers as well. Turning to the causes of hypertension in children, again, essential hypertension is at the bottom of this list, but we now know that it is increasing in prevalence due to obesity. There are a variety of secondary causes that should be evaluated, such as renal parenchymal disease, renovascular disease, coarctation of the aorta, and states of mineralocorticoid excess. Essential hypertension has had some interesting data in terms of potential causes of this, and one interesting area that's being studied is the role of hyperuricemia, or elevated uric acid levels. There's a long history of hyperuricemia and its association with hypertension, but until the recent development of an animal model, there was no way to study this more accurately. And with the development of this animal model and induction of hyperuricemic hypertension, these animals developed renin-mediated hypertension, and thus led to the question of whether this has some impact in children. And so this group studied the evaluation of uric acid levels in children referred to a hypertension clinic and found a relationship with primary or essential hypertension that was unrelated to GFR. This is important because decreased kidney function itself can be a cause of elevated uric acid levels. And this is from that table itself, with the graph on the left side here showing that primary hypertension uric acid levels averaged 6.3, where in secondary hypertension and white coat hypertension and controls, those readings were in the 3 to 4 range. And they found that if you had a uric acid level greater than 5.5, that was an 89% positive predictive value for primary hypertension, versus a normal uric acid less than 5 had a 96% negative predictive value for primary hypertension. So this was a rather dramatic effect. And they studied a small cohort of children where they looked at treating them with allopurinol, which lowers uric acid levels, and found that their daytime systolic blood pressure load, or an ambulatory blood pressure value of hypertension, decreased in those children. That increased once their allopurinol was washed out, and this correlated nicely with their uric acid levels. So this turned into a controlled trial, which showed that the drop in blood pressure was sustained with the allopurinol versus the placebo. Moreover, this was a crossover study where patients essentially were in both groups at different times, and it was demonstrated, regardless of which arm they were in, that allopurinol lowered their blood pressure, again, in children with hyperuricemia and hypertension. Moreover, this was seen to be associated with a decrease in systemic vascular resistance and a drop in plasma renin activity, suggesting that this might explain some of the mechanism for hyperuricemia and hypertension. It should be emphasized, however, that allopurinol as a treatment for hypertension is still a research concept and has not moved into clinical practice. Another interesting relationship is uric acid and fructose consumption. It's known that fructose induces the production of uric acid in the liver. And this is a study, again, from the NHANES data sets that looked at almost 5,000 adolescents and showed a trend for uric acid rise with increasing soda intakes. From the kids who were taking 36 ounces a day of soda, rather dramatic increase, versus those who were taking none. And you can see this trend here was statistically significant and associated with a significant increase in systolic blood pressure. Obstructive sleep apnea is an important concept, and we're finding more of this in children with hypertension. This has long been documented in terms of associations between obstructive sleep apnea and hypertension in both adults and children, but a number of studies have strengthened this relationship as possibly causative. This one small study from 2010 where it shows blood pressure improvements in hypertensive children after they had their adenoids and tonsils removed for sleep apnea. More recently, an adult study showing higher rates of resistant hypertension in spite of intensive therapy in adults, again, with those with severe versus moderate obstructive sleep apnea, 58 versus 29%, while those with severe obstructive sleep apnea had a fourfold higher adjusted odds of resistant hypertension. So there was a strong relationship in this cohort, which was a baseline data set of adults going through a study looking at interventions for sleep apnea and its effect on blood pressure. Another study, published in 2013, was a randomized controlled trial of adults with resistant hypertension and sleep apnea looking at CPAP versus no intervention for 12 weeks and showed that there was a decrease in the 24-hour mean and diastolic blood pressures and an improvement in the nocturnal blood pressure pattern. Again, these are all ambulatory blood pressure patterns, but all of these strengthen the relationship between obstructive sleep apnea and hypertension, and it should be screened for in children who you're seeing with elevated blood pressures. Moving now to target organ damage in children. While previously this was thought to be more of a benign disease in children, there's ample data now that supports the role that children, in fact, do have target organ damage related to hypertension. Some of these that have been described include left ventricular hypertrophy, or LVH, carotid intima media thickness, which is a vascular ultrasound finding, chronic kidney disease, and in fact some cognitive measures. We're going to look at LVH and CKD in the coming slides, but it's important just to note that the cognitive measures have been studied in some small data sets, and there's in fact a randomized controlled trial looking at different interventions for hypertension and its effect on subsets on psychoeducational testing. So LVH is the most common form of target organ damage in hypertensive children. It's found in about 30 to 50% of new referrals to hypertension clinics. And this one study looked at the higher prevalence of LVH, in fact, in pre-hypertension relative to children with normal blood pressure. And again, 6.5% in the normal blood pressure children versus 20% in this study in pre-hypertension and in hypertension, which makes intuitive sense as pre-hypertension is not a cutoff suddenly for hypertension, but it rather is on a continuum, as we discussed earlier. This is one study from 2007 looking at ramipril, which is an ACE inhibitor, studying its effect in children, and here looking at blood pressure effect of the ramipril in lowering blood pressure in this small study. While it showed a rates of about 42% LVH at onset, dropped that to 11% after therapy. So this is encouraging. That shows that LVH, in fact, is reversible in children with good control of their blood pressure. Moving to chronic kidney disease, this is a study of 250 children in Italy, children with normal BMI, so not obese, normal kidney ultrasounds where there's an absence of structural kidney disease. And in this study, they found that in pre-hypertension, they had a lower GFR and more proteinuria than children with normal blood pressure. What was interesting in this study is that the ranges of GFR and the ranges of proteinuria were both within the range of normal. So while this was a demonstrable effect, this was not a dramatic effect. So this is an effect that requires further study. However, in a large enough set, one could demonstrate that there was a trend and, in fact, a statistically significant change in GFR and proteinuria in the children with only pre-hypertension. This is a study from 2009 that looked at children with known chronic kidney disease and studied the effect of intensive blood pressure control versus standard blood pressure control in looking at the progression of CKD. The concept here is looking at control versus to the 95th percentile versus trying to lower blood pressure to the 90th percentile. And what's demonstrated here is that there was a change in the rates of hypertension. This is looking out 5 years in this study in both of these tables, demonstrating that in fact there was a change in GFR in kidney function 5 years out from this study. This was a population that had high rates of proteinuria, and what was shown that in fact that even at the end of the study period, which was 3 years, that their urine protein to creatinine ratios rose while their blood pressure stayed normal. 5 years. That the proteinuria was not an effect of improving their GFR, but in fact controlling their blood pressure was. Moving back to the patient that may be in front of you with high blood pressure, there are a number of important questions to ask trying to assess the cause of potentially of this hypertension. The first is, why was the blood pressure checked? Is this patient here for a checkup and was done as part of routine healthcare maintenance? Did this child present with some symptom that may have referred one to hypertension, such as headaches, chest pain, edema, urinary changes, or a history of urinary tract infections? It's important to look back at when it was last normal. We often find that in children referred for hypertension, that while they may have had an elevated blood pressure reading at their last checkup and a few readings after that to demonstrate that it was still elevated, in review of those readings going back, we can often find intermittently elevated blood pressures prior to that. So it's important to get a sense of what is the chronicity of this blood pressure. Medications are an important cause of high blood pressure in children. While decongestants typically by themselves won't raise blood pressure, we tell our hypertensive children not to take them, as they can certainly elevate it in those patients. Stimulants used for attention deficit disorder can raise blood pressure to some degree, and we'll talk about that in the coming slides. Oral contraceptives that contain estrogen are well documented to cause hypertension. Corticosteroids used for a variety of diseases, when sustained, can lead to elevations in blood pressures. Calcineurin inhibitors, which are used in pretty much all patients who get transplants, kidney and otherwise, have hypertension as a fairly consistent side effect profile. These are a number of studies looking at the role of stimulants in ADHD in elevations in blood pressure. The first is a study looking at almost 5,000 children from the NHANES data set, ages 12 to 18 years, so an adolescent population, who are found to have ADHD. In 11% of those patients, a third of those patients with ADHD were on stimulants, and they found that girls on stimulants had higher blood pressures than those who are unmedicated or in those without ADHD, while boys showed no difference between the two groups. Another study from 2011 showed that the blood pressure elevations are generally small, and that while there are certain subsets that may show higher blood pressure elevations, this is often not a dramatic effect. Nonetheless, it's important to screen patients who are on stimulants for hypertension, as this is an easily identifiable cause of side effects from this medication. Also important in the history is looking at what may seem as relatively innocuous symptoms. We often think of hypertension as a silent disease, but this study from 2006, looking at a wide variety of symptoms in children with hypertension, showed that 64% of children had some abnormality in this symptom survey that decreased to 28% with treatment and normalization of their blood pressure. Among the most common findings were 42% demonstrating headaches, while a quarter of them had varying findings related to either difficulty initiating sleep or daytime fatigue. Whether this is related to obstructive sleep apnea was not documented in this study. However, it's important to ask for a broad range of symptoms in these children, as we understand both from our target organ damage and from simply asking for symptoms that hypertension, again, is not a silent disease. Past medical history is important, including any other health issues. Premature infants and small for gestational age infants, both categories are known to have elevated blood pressure later in life. The mechanisms of this is not entirely clear. In some children, it's related to their chronic lung disease. In others, it can be related to the presence of an umbilical artery catheter that may have flipped small emboli into the renal arteries and into the kidneys. Prenatal hydronephrosis can often be seen whether it's obstructive or otherwise related to hypertension. And children with a history of urinary tract infections, especially infants, can be left with renal parenchymal scarring that can lead to hypertension later in life. Family history is also important, both in looking at primary hypertension as a cause of hypertension in children. There are forms of mineralocorticoid excess that are related to monogenic forms of hypertension. Granted that they are quite rare, but these patients often have a dominant pattern of inheritance, and so taking a good family history is important as well. Those patients often have a young onset of their hypertension in contrast to the average adult in middle age that may develop hypertension. There are certain forms of kidney diseases that are inheritable, such as hereditary nephritis, under which Alport syndrome falls, as well as polycystic kidney disease, which is thought to be one of the most common genetic diseases with a prevalence of 1 in 400 reported. Other family comorbidities as well, asking for early history of heart attacks, strokes, and vascular disease, looking for potential risk factors in those children as well. Turning to the physical exam, one should measure a blood pressure in the right arm and in a leg. This should be done with a manual cuff in the right arm as well, as we discussed earlier, as norms that are documented in children are based on manual blood pressures, as well as the effect of oscillometric or machine blood pressures and raising those in children. Looking at it at a leg is important because we want to document a coarctation that could be present, and normally the blood pressure should go up by 10 to 20 points in children with normal vasculature. Other features such as their growth parameters, looking for obesity or potential growth failure as a marker of chronic kidney disease. Certain syndromes can be associated with hypertension, such as Turner syndrome, which is associated with coarctation, or Williams syndrome, which can be associated with various forms of aortic and renal artery stenoses. Femoral pulses are also important to look for a coarctation as well, as those would be diminished in children with aortic coarctations. Certain skin findings can be associated with syndromes that are related to hypertension. Neurofibromatosis is a genetic disease that can be associated with various stenoses in the renal arteries and in the aorta, both intrinsic from fibromuscular dysplasia as well as neurofibromas that can compress the vasculature. Tuberous sclerosis is another dominant disorder that is associated with kidney findings such as renal cysts and angiomyolipomas, which can compress adjacent renal tissue and lead to hypertension. Certain types of glomerulonephritis are associated with skin findings such as the malar rash in lupus and purpura in Henoch-Schönlein purpura. And insulin resistance, seen in children with obesity, can have acanthosis nigricans, a darkening of the skin and thickening of the skin, commonly seen in areas of rubbing such as under the arms and on the back of the neck. Once hypertension has been documented, basic laboratory studies should be done to screen for kidney disease, such as a BUN and creatinine, electrolytes, looking for forms of mineralocorticoid excess with hypokalemia or alkalosis, uric acid, as discussed earlier. Thyroid is important, as hyperthyroidism can lead to hypertension. Although it's rarely a cause of hypertension in children, hypertension in hyperthyroidism is a common presenting feature. Fasting lipids and glucose are important, especially in obese children, to look for other risk factors such as hyperlipidemia, which is associated with cardiovascular disease, and hyperglycemia as a risk for insulin resistance or diabetes. Second-line laboratory studies, often ordered by specialists, include plasma renin activity and aldosterone. These are done to assess for forms of mineralocorticoid excess in states where the kidney is inappropriately retaining salt for whatever genetic reason, and plasma renin activity is then suppressed in those children. Aldosterone can be low or high depending on the specific genetic cause. but these are often helpful in those states. A normal plasma renin activity does not point us in one direction or another. Urine catecholamines or plasma catecholamines can be done to assess for pheochromocytoma or states of catecholamine excess. Looking at the urine is important. Urinalysis is an easy test to screen for kidney disease, assessing for things as hematuria and proteinuria. And we will often get some measurement, quantification of the urinary protein excretion if there is some abnormality on the dipstick. Imaging is an important adjunct in the assessment of children with hypertension, and there's some controversy around this, but most specialists will get some degree of imaging. A renal ultrasound is typically done to assess for the presence of two kidneys, whether they're normal structurally or if there's a size discrepancy, whether there is dysplasia or some other structural abnormality. And Doppler studies can be done to assess for renal vascular disease. However, Doppler studies are not the most sensitive way of looking for this. And even in adult studies where adults with renal vascular disease typically have main renal artery findings, Doppler studies are still not terribly sensitive. An echocardiogram is useful if one suspects the presence of coarctation, as this is diagnostic, but it's also helpful to look for left ventricular hypertrophy. Again, 30 to 50% of children presenting with hypertension will have LVH, and the presence of LVH is important, as we'll come to in a little bit, because it helps us target our blood pressure goals. There are a variety of second-line imaging studies that can be obtained. I've listed a number of them here. A DMSA scan is a nuclear medicine study that looks for scarring in the kidneys that could potentially direct one towards a cause of hypertension seen in children with old scarring from UTIs. An angiogram can be done to look for renal vascular disease, such as renal artery stenosis, and in a conventional angiogram done by an interventional radiologist, if a stenosis is seen, this can be also therapeutic with angioplasty done. However, due to the invasive nature of this study, specialists will often obtain some non-invasive form of angiogram, such as CT or MR angiogram, which is not a substitute for the conventional form, but can give one suspicion whether a conventional angiogram is indicated. This is an example of a DMSA scan of a 10-year-old girl who I saw in my practice who presented with severe hypertension. Blood pressure was 150 over 100. She was not obese and had no other history of any findings, except that she had a history of UTIs. And her ultrasound showed a size discrepancy between her kidneys. The DMSA scan here shown with the left kidney higher than the right shows that the right kidney has a small abnormality at the lower pole, while the left kidney has irregularities at the mid-pole and the lower pole as well. These are areas of parenchymal scarring from old episodes of infection when she was younger. This is an angiogram done from a patient with neurofibromatosis who had recurrent stenoses and actually had multiple surgeries to correct some of these. In this study, she has a stenosis at the beginning of the left renal artery and a more extended stenosis at the opening of the right renal artery as well. In this patient, she had multiple stents placed, and again, surgery is noted for correction of a variety of vascular anomalies. This is imaging from a patient who presented with severe hypertension, who not only had headache but also had postural changes, which made us suspicious for a pheochromocytoma. We sent plasma catecholamines, which showed a markedly elevated norepinephrine level, 1,000 times the upper limit of normal, and an ultrasound shown on the left side of your screen showed a 3.5 centimeter mass in the adrenal just above the right kidney. A CT scan shown here with the arrow pointing towards the tumor that had replaced the right adrenal gland, and this patient responded well to appropriate therapy with blockade of catecholamines, as well as surgical removal of the tumor. Interestingly, we now know that about 40% of children who present with pheochromocytoma will have some genetic abnormality, such as forms of von Hippel-Lindau or other related genetic disorders that can be causative and potentially a risk factor for recurrence of these diseases. So that's part of our evaluation of these patients as well. Turning to therapy for hypertension. In the typical patient with stage 1 hypertension who is asymptomatic and does not have demonstrable target organ damage, we'll typically begin with a course of therapeutic lifestyle modification. This is recommended by the 4th report guidelines and includes such things as weight reduction and dietary modifications. Important here that we'll come to in a little bit is the role of family-based interventions, as asking a child who is in an environment at home where a variety of unhealthy choices may be presented to this child to simply make changes on their own without addressing the family dynamic is a recipe for failure. The DASH diet has been long used in adults and in children for hypertension. DASH stands for Dietary Approaches to Stop Hypertension, and is sort of a common sense healthy living diet, rich in fruits and vegetables, low in saturated fats, and was shown in adults in a large study in the New England Journal of Medicine in '97 that lowered blood pressure. And not surprisingly, in those who had higher blood pressures, the effect was more dramatic in lowering them. In a follow-up study where the DASH diet was added to sodium restriction, there was an additive effect of lowering blood pressures, and even modest reductions in sodium intake were beneficial in improving the effect on the DASH diet. There are a number of papers now in children that have shown that the DASH diet and weight loss can improve blood pressure in children, so these are routinely recommended as well for children. The role of sodium restriction is important. There are a number of studies, most recently demonstrating that from the CDC, that show that the intake of children of sodium is well above what is recommended, regardless of age. About 3/4 of the sodium that we take in is from processed foods, and this is an important fact to remember. As soon as I tell a family that they should limit their salt intake, their first reply is, well, I don't cook with salt and I don't use a salt shaker. And that's great to hear, but it's important to remind them that most of the sodium that they take in is not from a salt shaker, but rather already in their food. There are multiple adult studies, again, showing the lowering of blood pressure with sodium restriction of varying degrees. And as noted on the prior slide, the higher the blood pressure, the more likely one will have an effect. There's some anecdotal data from Finland where there was a vigorous approach to reducing sodium intake some decades ago that they suspect has been responsible for significant reductions in stroke and coronary artery disease in that country. This is an interesting study from 2008 that looked at the role of doctors giving advice to their adult patients with hypertension and whether patients actually did anything with that. And they found that there were large numbers of them, surprisingly in fact, who changed their ways. 70% changed their eating habits, 79% reduced their salt intake, 2/3 of them started exercising, 58% who drank alcohol reported decreasing their consumption, and those significantly improved compared to those who did not get specific advice. I put this slide in here because when we initially think about providing advice for our families and children to change their ways in terms of healthier living, we're sort of overwhelmed with a sense of despair that they're not really going to do anything. And this study sort of makes us gives us pause and makes us wonder that perhaps we should be more vigorous in providing advice to our patients and perhaps even modeling that advice. When therapeutic lifestyle modification doesn't work, our next approach is to turn to pharmacologic therapy. And the goal of therapy is to reduce blood pressure to below the 95th percentile or below the 90th percentile if concurrent conditions are present. And what are those concurrent conditions? Well, below the 90th percentile is prehypertension, and some of those conditions include chronic kidney disease, diabetes, heart failure, or LVH. And these are patients, again, who are high risk for side effects or target organ damage from their hypertension, or those who already have target organ damage, such as LVH. And we want to lower their blood pressure below the prehypertension range to try and, in the case of LVH, reverse those effects, and in the case of CKD, to try and prevent or slow the progression of CKD as demonstrated earlier. In patients with stage 1 hypertension, we initiate therapy based on the indications for antihypertensive drug therapy, or if there are compelling indications as above. Stage 2 hypertension, regardless of whether they're symptomatic or not, we will typically treat due to the significant elevation. The choice of agent should address the underlying mechanism, and sometimes will have added benefit for comorbid conditions. So, for example, while we have a whole slew of choices of different categories of drugs for children with hypertension, sometimes we'll try and pick specific ones depending on the indication. For example, if we have children with chronic kidney disease or proteinuria, we'll often use ACE inhibitors or angiotensin II receptor blockers, as those have both been demonstrated to reduce proteinuria, which itself helps slow the progression of chronic kidney disease, as well as may have other effects on a molecular level that interferes with the development of interstitial fibrosis or scarring in the kidneys. In patients who develop hypertension related to the use of calcineurin inhibitors, calcium channel blockers are typically our first-line agent. While in patients with edema related to glomerulonephritis, we'll typically turn towards diuretics or in addition to calcium channel blockers. Certain agents such as alpha-2 receptor agonists, which include clonidine and guanfacine, have long been used for patients with various behavioral or psychiatric indications, including ADHD, and may have a role in those children who are on stimulants who develop hypertension and cannot come off of their stimulants. Vasodilators have been around for a long time, such as hydralazine, which is used in the IV form for severe acute symptomatic hypertension, or minoxidil, which has been around for many decades and is now only used in resistant hypertension, typically added to those, added for those children who are on multiple other drugs without effect. It should be noted that while many of these drugs were previously used off-label as there were not specific pediatric indications, with the development of the Food and Drug Agency Modernization Act in 1997, there are now agents from every one of these categories that have specific pediatric approval and dosing. And this has been a testament to the role of the pediatric hypertension community in advocating for doing those studies and getting those indications. So in conclusion, essential hypertension in children is commonly due to obesity and is now the most common cause of hypertension in children, where secondary hypertension used to have that title. A secondary workup should be done in patients who have severe hypertension, are not obese, or are resistant to therapy. But some screening workup should be done in all children who present with hypertension, as noted above. History should include evaluation of sleep quality and sleep apnea, as these are potentially reversible causes of hypertension in children. Therapeutic lifestyle modification is first-line therapy for those children with stage 1 hypertension who are not symptomatic and who do not have more severe elevations in blood pressure or other indications for therapy specific.